Welcome, everyone. Thank you for joining us for this really important webinar. We have very limited time this morning, so I will introduce myself. My name is Samantha Lee. I'm the Supervising Solicitor with Redfern Legal Centre. We won't be taking any questions today. This will be an hour-long seminar, but there will be ways of getting in contact with us. You can certainly get in contact with me via Redfern Legal Centre. Firstly, I'd like to acknowledge that I'm on Gadigal land, the land of the Eora Nation, and I pay my respects to elders past, present, and emerging, and want to acknowledge that the topic that we are talking about today has tremendous impact on First Nations people, and many First Nations people have been the recipient of excessive force and may have been suffering from a mental illness. So we will take that throughout the webinar today. I want to introduce our speakers. We have Lisa Topic. Lisa is the mother of Courtney Topic, who was fatally shot by police in 2015, who was only aged 22. She was suffering from a severe psychotic episode. The coroner described the police tactics leading to Courtney's death as entirely inappropriate. Lisa is a determined advocate calling for reform of the way we respond to mental health incidences. Thanks for joining us, Lisa.
Thank you for having me.
We also have Kate Wild. Kate is an investigative journalist who's worked with distinguished teams at the ABC and has been recognised with 3 Walkley Awards and a Logie. Her reports from Darwin, where she lived from 2010 to 2016, laid the groundwork for a 4 Corners story on juvenile detention that prompted the calling of the Royal Commission. She also wrote a book, and she grew up in country New South Wales. She now lives and works in Sydney. Welcome, Kate.
Thank you.
We have Dawn Ponton, who Dawn has 13 years experience with the New South Wales Police Force, focusing on youth liaison, child abuse squad investigation, and is serving as a subject matter expert with the mental health intervention team. She taught communication and de-escalation techniques for high-risk incidences. Dawn has advised senior police on the Mental Health and Forensic Mental Health Act. Before joining the police, she worked at the Department of Forensic Medicine in Glebe, managing the support after suicide clinic and gaining forensic counselling experience. She is now an independent contract investigator. Thank you, Dawn, for joining us. Last, we have David Everden. David is a solicitor advocate at Legal Aid New South Wales, where he currently practices in crime. He has appeared throughout New South Wales as a defence lawyer in criminal trials and sentences. He also has extensive experience in the coronial jurisdiction, appearing as an advocate for aggrieved families, including Lisa Topic's family. David managed Legal Aid's coronial inquest unit for 5 years, and developing in that time expertise in First Nations deaths in custody in general. He was recently appointed as part-time lawyer member of the New South Wales Mental Health Review Tribunal. Welcome, David.
Thanks, Sam.
Okay, we're going to get straight into it today. First, I want to set the scene in regards to first responders and attending to mental health crises. David, I'll first go to you. Can you give us a quick overview of the current first responder model? What laws and policies govern this model at the moment?
Thanks, Sam. This is such an important subject. When we have a mental health emergency in the community, various forms of crisis and emergency mental health care are available. This starts with helplines and mental health clinical triage services and moves on to crisis assessment and treatment teams who attend on people in the community. Of course, there's the option for people to present at emergency departments themselves. And then in terms of first responders, we have the police and ambulance, who in practice are often first responders to a mental health crisis in the community. In 2021, 2022, half of mental health presentations to emergency departments were people that had been brought in by the ambulance service. In comparison, only about 6% of presentations were brought in by police. But despite that, police recorded around that time a staggering 61,000 incidents in 2022 of people experiencing a mental health emergency or incident, which included over 20,000 incidents where police say they used their powers under the Mental Health Act, specifically under Section 22 of the Mental Health Act, to apprehend and convey someone to an emergency department involuntarily. So it's worth noting that police have both powers and obligations under the New South Wales Mental Health Act. Section 22 is a specific power which provides them with an ability to apprehend someone and take them to a mental health facility only in specific circumstances. For example, the person's committing or recently committed an offence, or they've recently attempted to kill themselves, or it's probable they might either do that or cause serious harm to themselves or another. So if those conditions are satisfied and a police officer thinks it's necessary and beneficial to take someone to an emergency department, then that can take place. Police not only have those powers to transport someone in those circumstances, but they're also required to assist if the ambulance requests, or if, for example, under the Mental Health Act, a doctor or another mental health clinician has issued a certificate that requires a person to be taken to hospital. Police can be asked to assist in those circumstances. So we do have a variety of powers under the Mental Health Act where police are specifically required to do things. Another example is people being treated in the community under a community treatment order. If they breach that order, police might be asked to transport them to an emergency department. So it's the case that even though the functions of police are, or the core functions are set out under the Police Act, those being to detect crime, protect people from injury or death, we also have other functions under the mental health legislation. In terms of policies, since 1998 in New South Wales, we've had various iterations of a memorandum of understanding between New South Wales Health and New South Wales Police to provide a framework for effective management of people with mental illness or disorders. And by that, I mean a response framework for mental health emergencies in the community. And that framework only requires police involvement where it's requested under the Mental Health Act, or where there's a threat to public safety or some sort of serious risk, an assessed serious risk. So it's important to point out when we think about first response that New South Wales Health is the lead agency in responding to mental health emergencies. And typically it's the role of the ambulance service to respond unless police are required. Ambulance officers have their own powers under the Mental Health Act. The reality, though, with all the pressure we have on our ambulance services, is that it doesn't always work out that they're the first responders to a mental health crisis. Police are often triaged to attend if there's any suggestion of violence. And the reality, I think, is very different to what should take place under the MOU, particularly in rural and regional New South Wales, where police are often being called on to attend mental health emergencies.
So that's interesting, David, because in some ways you're saying we have a health model framework existing, but it really doesn't operate in practice.
Yeah, that's right. And I think the problem with that is that police have consistently failed to train their officers in relation to mental health and de-escalation. And I mean to train them effectively. And in the coronial space, we've seen many recommendations from fatal police shooting matters over the years that have sought action and recommended improved mental health training for police officers.
We might then move it then, David, to Dawn to tackle that issue around training. So it might be a good segue to move on to training from there. Dawn, I'll just bring you in here. As David said, there are over 60,000 mental health incidences in the community every year. can you provide the audience with an overview of the training police receive to handle mental health emergencies?
Yeah, thanks. Look, I think from 2012, the New South Wales Police Force had a world-winning training program, a 4-day program that was initiated through, it's actually Dave Donahue, a brilliant initiative from basically going to the States, doing their homework, bringing it back to Australia. And that meant 4 days of officers every month going off-site, living and breathing the mental health space, mental health consumer world for 4 days. Incredible. It was a world first, really, for training for police here in Australia. That was highly successful. The key being practical training and listening to subject matter experts from every aspect of mental health. And I would like to point out, particularly given that it's in the press at the moment, is a subject matter expert who would talk about dementia and Alzheimer's and how to, to communicate and de-escalate. So a lot of practical training with the 4-day program that happened for several years. And that went through to, I believe, to 2020. Changing of the guard meant that in terms of reaccreditation for the 4-day program, it basically, in summary, went to 2 days of training. And they basically, I think, filmed all of the presenters from the 4-day training and condensed it into that 2-day training. So something has to give when you're condensing into 2 days. Mm-hmm. As a result of the shootings that happened, particularly with Courtney Topic, and Mockmull and Hodge in 2015 and then 17 with Mockmull, I believe that there was a commissioner's directive that all police from 2020 would have to do mandatory e-learning on the Stop-R model, which was a practical model, but again, still online. So we've gone from a world-class 4-day training to 2 days, mostly some of the training was done pre the 2-day training that the officers would have to do in their own time online or reading. And to date, there is I believe, no practical training for police at all, which to me it's just insane. I think that is the key. Yes, you've got to have e-learning, you've got to read, you can look at videos, you can, look at all sorts of things, but police really need to have the practical training, and they do not have any. I believe they're going to have some face-to-face training in the coming weeks, but that's face-to-face training. It's not practical. It's not role plays. It's not actually, okay, we've got a scenario here. Let's go through it together. Practical training, we know, for police really works. And one of the things that I've observed is that since we've had armed offender, we've had the shootings. You mentioned the Westfield shooting. So police have gone off site to do active armed offender training, which is mandatory. Police have to go off site to a campus and do a lot of physical training for that. We don't have a lot of that threat here, thank goodness, in Australia, but we do have high-risk mental health incidents every day. And that's where the practical training, in my opinion, should be, is that bring it back, because that's what police really, they can take it on board, they can relate to their own learning, personal experiences with that. I think
Dawn,
that's where we failed.
Leave you there, and thank you. obviously the emphasis is on practical training. I mean, the problem with e-training is that you don't even know if anyone's even engaging with that subject matter through e-training.
Correct.
I'm going to move on to Lisa now. Just a warning that it is a very heartbreaking story that Lisa is about to share. Lisa, would you mind telling the audience about the day that Courtney was fatally shot?
It was an ordinary day. The family all went off to their normal, work and things that they had to do. It was a Tuesday the 10th of February, 2015. Courtney didn't work on a Tuesday. She worked at Woolworths up the road from us, and she'd worked the night before. Again, a normal evening. That morning, I was coming down the stairs here at home, and I saw her going into the bathroom, which is opposite the staircase. And I said, "Bye, Courtney, have a good day." She didn't respond. That's all right. She was more asleep than awake. Again, ordinary day. I went to work. My husband went to work. Our son went to school. Our other son was going out with his partner, and our other son was going out. Nothing out of the ordinary. An ordinary day like today and every other day. Anyway, I'm at work. I worked at the local Catholic primary school up the road, 10 minutes from where I live, which is virtually 10 minutes from where Courtney was shot. It was about 2 o'clock in the afternoon, maybe 1 o'clock. Some of the young staff members came in and said that a young girl had been shot dead at Hungry Jack's. She was about 16, and I remember thinking to myself, wow, that's awful. How close to home? This is scary. Not for a moment thinking it related to us in any way, shape, or form. Courtney Courtney had ADHD, inattentive, so she'd just get lost in her own mind. And following school, she was diagnosed with ASD, so Asperger's on the autism spectrum. Courtney didn't go out on her own, so there was no inkling that that could have been my daughter. She left the house with her mother, me, her dad, or her brothers. She'd go to work on her own, which was 2 streets away. She'd walk and she'd have her head down. She wouldn't engage with anybody. So it had nothing to do with us until it did. And then, I'm thinking I better ring her, and because I could hear helicopters and so forth, and let her know that something's going on. It might take me a while to get home from work, just giving her a heads up. And there was no answer at home. And Courtney had a mobile phone, but she didn't use it. I didn't think too much of it. Courtney often had headphones on, listening to music, or so we thought at the time. And you could check my phone records, probably 15, 16, 17 times I rang the home phone, nothing. So I rang my son, who was coming to pick me up. I wasn't driving at the time, and my husband. So it was all still about, oh, it might take us longer to get home from work today. It was nothing to do with us. And then about 2:45, over the loudspeaker, I worked in a school, was asked Mrs. Topic and my boss, Mr. Lacascio, please come to the office urgently. And I remember thinking, oh, that's what's going on. Is not again at any time thinking this involved Courtney. It was least likely to affect Courtney. I thought it could have been one of her brothers that had a car accident or something. One of her brothers was on red P plates. We thought, so Courtney was the furthest thing from my mind, in that if there was an incident, it would involve her. Sadly, that wasn't the case. Got to the office, and there were detectives there from Cabramatta Police Station. And we went into my boss's office, and they said, your daughter's been shot dead. And I said, no, what do my daughter's at home. Straight away, it didn't make sense from the get-go. And honestly, we're coming up for 10 years. It still doesn't make sense. It shouldn't have happened. It did. So we need to make change. She went out that day. We since learnt through the coronial inquest, through the forensic psychiatrist who went through and looked at her history and so forth. And we found out posthumously that she had suffered her first major psychosis that day. Now, that should not have cost her her life. She should have been assessed in a medical sense and then taken to hospital for the appropriate treatment. And we wouldn't be here today. My daughter would be alive. She will still have, more than likely, still have mental health issues. she'd suffered with mental health throughout her short life, but she was working, she drove a car, she was living a normal life, albeit it was a little bit trickier for her than most people, but she gave it her all and she tried her best always. That day, from that moment on, it became almost I had to go into mother mode. I was worried about my other children, worried about my husband, worried about my parents who watch all the newses and so forth. So it was pretty much going into mother mode and trying to make sure everybody was okay. And then being the person to tell them, when my son came to school to pick me up, and, I wanted to be the one that told them that their sister was dead at the hands of police. I didn't want other people telling them. So fast forward, and I don't mean fast forward, it was hell, but fast forward to close to 6:30 that night. We're all in my boss's office at school. Detectives from Penrith had organised to get my son on P plates and his partner down to us. They were wonderful, couldn't fault them. The detectives from Cabramatta were wonderful. They all got us down to my parents' house because we didn't want to go home because it meant going past Hungry Jack's where Courtney was shot. It still wasn't real at this stage. And so we went to my parents. My parents had seen it on the news all evening, all afternoon, but hadn't for a moment thought that it'd be in relation to them. Again, Fairfield Police went and spoke to them. By the time we got to Mum and Dad's, 6:30, 7 o'clock that night, there were people there, people from school, people had taken food and so forth. We'd all got there and we're all just looking at each other. There's a mistake. There's something wrong. This cannot be true. They said it was a 16-year-old girl in the media. It was a zombie, so forth. We're trying to make sense of something that was the furthest thing from would have made sense to us. But we had no other option. At this stage, we weren't told where Courtney was or what was going on. So it was all very fresh in that your daughter's dead. Okay, all right, your daughter's dead. What does that mean? What does that mean? Well, she was shot dead by police. And that's all we knew. We had no further information at that point in time.
Lisa, could you take us through what actually happened at the incident, what you found out happened between police and Courtney?
I can do. It turns out about 10:30 thereabouts that day, Courtney decided she was going to walk to Hungry Jack's, which is about a 20-minute walk away. Courtney loved frozen Cokes or slushies. And it was her birthday a few weeks later. And what we've been told is looking at writings and so forth, she was trying to challenge herself to do more in terms of her mental health and things.
Mm-hmm.
Now, Courtney did go for a walk there with a kitchen knife from my kitchen. I did my training pre-apprenticeship training as a chef. My family had bought me my knives and so forth. They'd been in our cupboard for years since I was a teenager. So that wasn't anything out of the ordinary. As it turns out, Courtney had taken that kitchen knife with her. And through the forensic side of things and the psychiatrist and so forth, they had come to the conclusion that Courtney took it because she was paranoid that someone was going to hurt her. She was hearing voices telling her that someone was going to get her. Now, this all came out later. We knew nothing of this at the time. She walked the 20 minutes and there were calls for welfare from the public. There was a truck driver. I think there was somebody in a car, and they were all for welfare, all for self-harm. And the police received that. They were transferred from their communication department. But when the officers, or according to the officer during the coronial inquest, they said they didn't hear any of that. Now, it has been proven that they were told that and so forth, I'm not here to debate that. The thing is, it wasn't taken on board by those officers that this was a mental health welfare. All they heard was, she's got a knife, she's got a knife, she's got a knife. Yes, she had a knife. And they're not to know what the intention of her and that knife was, absolutely. But where it falls down is they did not assess the situation. Courtney didn't respond to any of the police lights, any of the commands. She was in her own world. And I think the Daily Telegraph put on the front page of their paper, zombie. Now, I take offence to the word zombie. She wasn't a zombie. She never was. She was in the midst, as we now know, of a psychosis. And she was oblivious to what was going on around her, including police sirens, police commands, police, everything to do with the police. She did not react to having a taser pointed at her.
In fact, there was one point, Lisa, where she ran. Is that's happened at one point?
There is. There were two officers that came up in a car, a senior officer and a constable that was on probation for 4 months, 5 months or something. They both got out. She had the taser. He had his gun drawn. And then they were there trying to, well, asking Courtney to drop the knife. Drop the knife was what everything kept happening. Drop the knife. And as that all happened, another officer from Highway Patrol turned up, jumped out of his car with capsicum spray and blindsided Courtney. Courtney didn't see that coming. The inquest showed that there was capsicum spray in her eyes, her glasses. We've got her glasses upstairs. She didn't see that coming. And as that's happened, Courtney was asthmatic and got allergies. From the vision, she's been like a scalded cat. And that's my opinion. She's fight or flight mode. And she's tried to run to get away from that threat. But the other two officers have made the triangle of safety. I use the word safety loosely. And that was the direction Courtney ran, because it was the direction heading back home. And as she got closer, and I mean close to point blank range, the officer felt that his life was in danger and she was shot through the heart. All that took 41 seconds after those officers arrived on scene.
Yes, it's the time factor, isn't it, that it really does get to me when I read the coronial inquest, Lisa, into Courtney's death. Thank you so much for sharing the story. I think just because of time, I might just move to David, who did represent you in the coronial inquest. Courtney's family and yourself. And David, I just want to, if you could just, because of time, just delve into some of the key issues that were raised during the coronial inquest and some of the recommendations that came out of Courtney's death.
Look, when we looked at that incident and when the coroner looked at that incident, it was all of the mistakes that were made by police leading up to what happened that got analysed. So the first thing the inquest did was looking at what happened and then looking at police policies and procedure and training and whether what police had done was appropriate. And the coroner found that this was very much an avoidable death. The police failed, as Lisa said, to take any notice of information that was broadcast over the radio. They didn't do any planning. The two attending officers literally turned up and one said to the other, "Have you got your taser?" And then they ran out. And then this third officer just ran up totally unexpectedly. At the same time, they were shouting at Courtney, drop the knife, not adopting any sort of de-escalation techniques. So there were 10 recommendations that came out of the inquest. A large number of them were about training. At that point in time, the police had this 4-day MHIT trained program, which Dawn's talked about. And the idea was that there'd be a priority response to that. Police were still saying that would happen at that stage. We've come to learn in the years that happened that model simply wasn't implemented, and police have abandoned the idea that MHIT 4-day trained people would respond, and they've also abandoned, as Dawn has said, that entire program. So big issues with training. We also raised issues with the actual response model that the New South Wales Police have. In Victoria, they were able to halve their police shootings in the 1990s by taking on some operational safety principles that actually required police to minimise their use of force and judge the success of an operation by the extent to which harm was reduced or avoided. New South Wales Police have nothing like that. They have a tactical options model which mandates that police must get in and control. The ultimate goal is control of the situation. So we argued against that. There was an expert in the topic matter from the UK, and as you probably know, in the UK, police are unarmed. They don't go around with guns. and the expert evidence that we had in the inquest was that there would never have been an armed response to the incident involving Courtney if that had taken place in the UK. So we have to start questioning.
Why is that, David? What would have happened in the UK?
The evidence from that officer was that taser armed officers may have been deployed, but the system in the UK is that it's only in particular circumstances that armed officers with guns will attend. So we really need a big rethink of our response system. I think New South Wales Police, just in terms of their tactical options model, giving officers the choice to do whatever they like, and the failure of them really to engage with the idea of how they can deal with a mentally ill person with a knife in a way that ends up in a peaceful resolution of the matter.
Thank you. Kate's been sitting there very patiently. Thank you, Kate. I'm going to move to you as we just delve a little bit more into the complexities in regards to these issues. Kate, after a six-year investigation into an incident, you wrote a book about it in 2009 about the shooting of 24-year-old Elijah Holcomb in the country town of Armidale in New South Wales. Elijah struggled with mental illness. He was shot by a senior constable who claims he had no choice other than to shoot Elijah because he was roaring at him with a knife, he tells. Some witnesses to the shooting say otherwise. Can I ask you to speak about some of the complexities surrounding this police shooting?
Sure. They're all the complexities that Lisa talks about and that Dawn dealt with every day that she provided training to New South Wales Police in the mental health intervention team, and that David would see every day in the coronial court. Elijah was shot in 2009. He was in his early 20s. He was having not his first, but one of his first psychotic episodes. He was receiving a lot of mental health care from his family and from the hospital in Concord. He was getting the best possible care you could hope for. As a lot of people who go on heavy medication for psychosis, he decided to stop taking his medication for a period of time, which brought his psychosis back on. He was he had a paranoia. He had a fixation that he was going to be killed by the police, which complicates his story, particularly for police officers who then have to deal with that as part of the situation. And that's a very common situation for police and a common situation for people in psychiatric crisis, is that people who are figures of authority, particularly police, someone in uniform, often will get drawn into somebody's distorted thinking. So Elijah, to cut a long story short, Elijah was on his way to the hospital to go back onto his medication. His dad left him alone in the car for a moment and his psychosis returned. He ran away with his dad's car and turned up in Armidale. He had the full range of interactions with police, from turning up at the Armidale police station because he felt safe to go there and say, I'm not feeling well, I need some help, can you take me to the hospital? Which happened. These senior officers there took him to the hospital for care. In the meantime, though, his parents, Elijah's parents, had gotten in touch with the police locally in their hometown of Narrabri and Wee Waa to say, this is the story. Our son's taken off. He's not well. He's desperately afraid of the police. Don't approach him because he will think that you're going to hurt him. Let us know when you find him and we will come and get him. Communication confusion is a very common factor in these cases that come to coronial attention. This was the case for Elijah. That message was not passed on the way that it should have been, or it was not received the way it should have been. Similar to the story that, to Courtney's story, where a third police officer turns up unexpectedly. Elijah made it to the hospital. He was dropped off at the hospital, but partway through his assessment, his psychosis returned, or his paranoia returned, and he decided he wasn't safe at the hospital and he walked out. He was a voluntary patient, so that was his right. But the staff at the hospital were very concerned about his safety, so they called the police to go and find him. We've had a guy who we think is unwell and we're worried about his safety. Can you please go and find him? In the meantime, Senior Constable Andrew Rich, who ended up being the shooting officer, had been asked to find the car that Elijah had dumped somewhere. That was all he'd been asked to do. He'd been given no information. He hadn't been asked to find Elijah. He hadn't been given any information about Elijah's mental state. But when he arrived at the hospital and they said he's gone off somewhere, Andrew decided that he would find, Senior Constable Andrew Rich decided he would find Elijah and ask him where the car was. He was in plain clothes, but he had a gun. He approached Elijah in the street and said, you know, I've got car keys, where's the car? That fed immediately into Elijah's psychosis that the police were going to kill him and were after him. Andrew had no powers at that point to pursue Elijah, the coronial found, but Elijah ran away because he thought he was going to be attacked. Andrew chased him. Elijah ran through a cafe, picked up a knife and went out into a back laneway. There were very many eyewitnesses who gave a range of views, from Elijah was standing still and not threatening anyone, to Elijah took a step back, to Elijah was running at Andrew Rich when Andrew made the decision to shoot Elijah. So there are common elements in Elijah's story and complexities that are alive in all of these cases where there's a fatality with the police, contact with someone in psychiatric crisis, poor communication, poor understanding of what police powers are, crossover between the health and the policing system, and time. Time is the absolutely crucial element, which I'm sure Dawn can speak to really clearly, but police are trained to deal with people, to get control of a situation, because that's usually what we want them to do. But in a situation where someone is in psychiatric crisis, doing that quickly can be fatal.
Kind of feeds into what David was saying, Kate, around the tactical response, as opposed to a different response.
It does. And I have to say, I understand everything that David's saying. I do sort of depart from him a little bit in his expectations of police in this space, partly because I've sat through the training course that Dawn used to give to police, and also because I've had personal experience of trying to deal with someone in psychiatric crisis, and I've tried to put into practice what I saw the police trained to do, and I realised just how incredibly difficult it is to do, particularly when police are trained to deal with things in a particular way, and a lot of the time that's how we want them to deal with things. But when they have to sort of turn on a dime and act in completely the opposite way in a certain situation, that is a very huge expectation to have of an individual human being. I'm not saying that it's impossible, but I think it can sometimes put the responsibility in the wrong place, in that, in my view, police should not be put in the situation where they are having to deal with someone in psychiatric crisis. If our health system was operating more effectively and we were providing people with the care that they needed at the right point in their situation, the police wouldn't be in the situation, and the person in crisis wouldn't be in the situation where there's this mismatch of skills and needs.
So a bit more prevention rather than
a lot
cure.
more prevention, so that police and people in crisis are not forced into that crucible of crisis.
And Kate, I just want you to just go a little bit into what you explored in your book, which is also the impact of on police when they shoot someone. And when we're looking at this topic, it benefits everyone to have a model that works. If you could just touch a little bit on that for us. Sure.
So in the process of writing about Elijah's shooting and his death and what led to it and what came from it, his case was in the court for 6 years, and unfortunately there were a number of other police shootings of mentally ill people in that time. And so I looked at all of them, and I looked at what it was like for the police to be in that situation, what it was like for the people in crisis. And there is no police officer who was left unbroken by the experience of having taken the life of someone. There were police officers in Victoria who I genuinely believe were forced to shoot a teenage boy who was armed with 2 very large carving knives and running at them. They did all the things that they were trained not to do in order to try and avoid killing this young man, including firing warning shots, including firing at his feet, doing all the things that they trained not to do to desperately avoid having to take his life. Andrew Rich, who took Elijah's life, suffered from PTSD, desperate PTSD, and left the police force. Many of these officers end up leaving the police force. It's not good for the entire community for anyone to be involved in a fatal shooting. Families disintegrate. The police force loses experience and knowledge, and loses people who, if they can be supported through a difficult situation like that or difficult experience like that, could bring that wisdom and that knowledge to the rest of the police force, and be a source of education, not another broken person.
Thanks, Kate. Dawn, I might bring you back in now, and actually, David, I might draw you in on this discussion as well. I want to go into a bit of scenario, looking at particular scenarios that do come up in current situations. So, Dawn, you talk communication and de-escalation techniques for high-risk incidences, what we have been talking about in this discussion. You also helped in the development of the MOU between police and health. Now, there's probably 2 major scenarios that come up, and I also know it in my practice. The first scenario, if we can just step through that, is when police are called, for example, to a flat or a house after a neighbour calls police concerns for someone's welfare. The police attend and the person is showing signs of being mentally unwell. They are by themselves and they're in their flat and they speak about hurting themselves. There's no one else around. When the police first arrive, the person is not armed. The person is no threat to, it seems to be no one else but themselves. Dawn, and I guess David, you might want to come in on this as well, but can you just talk us through what kind of things should be going through a police officer's mind in that situation? How should they approach it?
Yeah, sure. Well, since I left the force, we now have a PACER model where this would be an ideal scenario where there would be a clinical nurse consultant or a clinician, a nurse who would be on site. The ideal situation would be that they would be with the police officer to basically do the consult on what was happening at the time. That's been happening since 2020. The PACER model only works if the person is not violent and doesn't have a weapon. So therefore, it's just totally over to police. That's my understanding. Previous to that, look, I think it should be that it's all about communication. It's asking the question. The person that you're talking about might be in a deep depression, clinically depressed. Everything's going to be slow. They might not be able to communicate as quickly as we would like them to. So it's slowing everything down and just matching, okay, tell me what's happening for you right now. Often anyone who's going through a psychotic episode, a depressive episode, and they're in that crisis, that moment of crisis, they're terrified. And this is what we need to tell police to do, to keep remembering, is this person is terrified or totally confused. So we need to just keep calm, slow everything down, just ask them gently, what's happening for you? Are you hearing voices? What are the voices telling you to do? That's a great safety, a safety thing for us, because we need to know if they're hearing voices. Yes, they might not have a weapon, but they'll be able to say, yeah, actually, I want to hurt myself. That gives us we can work with the Mental Health Act then. We can say, okay, you want to hurt yourself. Tell me some more about that. In what way? Do you have a plan? What are you thinking of doing?
Dawn,
And
can I just ask you, in that scenario, if police turn up in uniform, does that have any impact on that situation?
yeah, great question. I think when we looked at what was happening in the States, the crisis intervention models across the States, where someone in uniform, or maybe if it was the crisis intervention team, nobody wore uniform. They wore a uniform, but it was sort of, you know, every day. It was a polo shirt and something else, to just take away that fear of you know, police. Or I mean, if we talk about people who've come from war-torn countries where they've been traumatized, seeing a police officer in uniform is terrifying for them. And you know, that's the way it is the police rule. The police hurt you, the police will kill you. So I think that's a really good point, is that we should still be, or police should still consider having a non-uniform approach to mental health jobs. Yeah. Yeah.
Dawn, I like your point of slowing everything down. David, can I just bring you in here as well? What's your take on how police should approach these scenarios based on your experience around these coronial inquest matters?
Look, I think the reality is that police are often called when there's some sort of concern for welfare, or people that are at risk of self-harm or suicide, and they often spend a lot of time dealing with those matters. That said, I don't think it's necessarily the appropriate response. Dawn mentioned a PACER. PACER is a very limited program. It involves some clinicians being involved in some police area commands. It's not rolled out in the regions. Often the clinicians are just 9 to 5, so no attendance at night. No attendance necessarily. Those clinicians will stay within the police station. And we've got a government that hasn't committed to PACER beyond 2025. They're effectively it's going to be phased out. So PACER isn't the solution, or PACER could be a solution, but it needs to be amped up and put on steroids. I think the answer is, going back to what Kate said, is that system-wide we have to be bulking up the ability of mental health teams that are health-led to get out to some of these incidents and to assist these people with a mental health response. No doubt there are very caring police that spend hours trying to, for example, deal with someone who might be on the edge of a cliff, but we're far better off with a response that's that comes from mental health trained clinicians.
Thanks. Can I just quickly, before moving to Kate, just throw in the scenario where, for example, that person in the flat moves out into a public space with, say, a knife. Are there differences in that scenario, how they should be approached, Dawn?
Oh, absolutely. Yeah, I mean, but again, that comes with, you know, specific training. Starting at the academy with, you know, yeah, is basically, it changes the scenario. Police are trained to, as you said, you've all said from the beginning, control the situation in a manner that is going to be safe for the person with the weapon, whatever that might be. And I do go back to actually Courtney's matter and think of what happened in that scenario. Is just the stop arm model is just, you know, just giving some space and time, as you said, Kate. Nothing has to happen immediately. You know, it's almost going into the realm of negotiation, which yeah, it's another topic, but is to just slow things down, give things space, even if the person has a weapon. And again, you know, police aren't clinicians. Police, it's not. There isn't an amount of time that is given to police in training on how to communicate with someone who's psychotic and is holding a samurai sword or whatever. So yeah, absolutely.
So Dawn, do you think police should be involved in these scenarios?
I do to some degree. I mean, magic wand. With the concern for welfares, I believe at the moment there is a current position that police do not attend concern for welfare. That's my understanding at the moment. In terms of weapons, absolutely, because it's about protecting the community, protecting, you know, safety comes first to the public, to the person who's psychotic as well. Yeah, absolutely. When there's a weapon involved, I think we should always be present. But it's difficult to expect police to communicate with someone who is not necessarily a criminal, but someone who's so unwell that they can't. Their world is not within our world at that time, and that's very tricky. That's very tricky for police to have to deal with at the time. Yeah.
David, a couple of points from you.
For me,
Yeah, about in the public realm, around safety and how to approach that.
yeah. So as I said before, under the MOUs, police have always been tasked to assist if there's identified risks. And the reality is what can be hard to do in these circumstances is to triage these incidents with limited information. So it might be a member of the public who rings up. In Courtney's case, there were clear indications from the people that rang that they thought Courtney might hurt herself and she was acting oddly. No suggestion of a threat to anyone else. But of course, there are incidents where people might be armed in public. We often don't find out until later on whether they're mentally ill or not. So at a coronial inquest, we have this great capacity to dig back and look at things in retrospect, but we don't always have all the available information. So one of the advances we need in our response model is to be able to identify people that are experiencing a crisis and get access to medical records, for example, immediately. That's not something that the police, as I understand, at least historically, have been able to do. And there's been a reluctance to seek sort of mental health intervention in larger incidents, for example, siege type incidents. Police have gone it on by themselves when there really should be a health-led response.
Thank you. Kay, I'll just bring you back in. What I want to look at now in this last part of the webinar is to look at what a first responder model should look like in the future. In September this year, the New South Wales Police Force released a mental health review. A senior police officer travelled to the UK to consider its right care, right person model, which ensures the right agency, that is the agency that can help the most, responds to the mental health related incidences. You have had a look a bit at this model, and what are your thoughts about implementing it in New South Wales or something similar?
Look, on the face of the reading I've done, it looks like an incredible model. It looks like a very fit for purpose model, to my view. So it started in sort of the point of it, the point of the right care, right person model is, as you say, that the right clinician or right expert is sent to the situation where the person's in crisis, so that the person in crisis is getting the kind of care that they need, and the person who's arriving has the expertise to help them, so that you're not putting, you know, apples and oranges together. It started in about sort of 2021, 22 was when it was first applied, just in one small, entirely small, but one police area in the UK. But as of April this year, it's now policy for all police forces in England and Wales to roll this out. And so it's a very locally, the idea is that it's a very locally based program. And so the local police force, and in the UK, if people don't know this already, similar to the US, in that police forces are attached to like a local government area. So they're very, very much a local organisation. So the local police force, the local health provider the local mental health teams and the local community operators all sort of build an MOU together to decide who will respond when. And the basis of it is to make sure that police are only turning up when someone's life or someone is at threat of harm or a life is in danger and a crime has been committed. And if those two things aren't met, it's not a police job. And it's really what I observe it is capable of doing, and what I think it aims to do is to just shake up our thinking about this idea we have in Australia that the police are the answer to everything. They're not. We've just become used to that because we have defunded so many other parts of our social fabric that, a bit like teachers, police are sort of pushed into the gaps wherever they are. And this model shakes that up and refocuses on a health issue gets a health response. A crime issue or a danger issue gets a police response. I think it's really worth looking at.
And I guess this kind of model requires a specific level of funding. Do you know anything about the funding levels or how it's distributed?
I don't have figures on the funding. I have read coverage from the people who sort of set up Right Care, Right Person, that the original Humberside Police who started the whole idea, to say that since they've got it working there, it has had an impact on funding being shifted to where it's needed. So the police get time back where they're not responding to mental health call-outs or welfare call-outs or call-outs to emergency departments to bring people back. None of those things are a police job anymore. So they're able to do other work. And because that pressure then returns to the health sector, the pressure is on the health sector to respond to those things, and the police and the health sectors are working together to enforce that pressure to land where it needs to be. Governments have been forced to fund the health services, particularly mental health services in that region that are needed. And so there's been a redistribution of funding to a part of the pie where it belongs.
Thanks, Kate. I'm going to quickly, before I want to give Lisa the last say in this whole discussion, I think we've partly answered this question, Dawn and David, but the police union have been making moves in association to extract themselves, police, from mental health incidences. Should they be extracted, or do they have a role to play? Just a quick two or three pointer, please. David, I'll go to you first. Yep.
Sure. Look, I think they will always have a role to play because it's impossible to accurately triage everything. So, for example, Kate just talked about Right Care, Right Person and sending police if there's a life in danger or a crime being committed. Almost every one of the avoidable police shooting deaths I can think about would still result in a police response. Courtney's case would result in a police response under that model because she's got a knife in public. So would, for example, the cases of Ian Fackender or Todd McKenzie. All deaths that I think were avoidable. So we are going to always have police involved. I think that we can't give up on the idea that police have to completely change their training and change their response model, because you're not going to bring 60,000 mental health attendances per year down to zero just by bulking up the health response. So police have to be trained properly and they have to have a different response model.
Yeah.
Thanks, David. Dawn,
So,
just quickly.
Yeah, I understand it's up to 64,000 incidents to date. I believe that as of last Saturday night, St Vincent's Hospital had a build-up of mental health cases where VKG advised that there were 10 mental health jobs that police had in holding and could not present to St Vincent's Hospital because they were chock-a-block. There was no capacity to deal with those. So I think the issue is definitely, it needs to be looked at across not just police but health, and come back to the drawing board about just how it's going to work. And I love that model, Kate. I think that's you're onto something with that. Brilliant. Go the UK. Yeah.
Okay, thank you. Lisa, I just want to quickly bring you back in. You've reflected a lot on Courtney's death, and the reason why you're here today is because you want to continue to advocate on behalf of Courtney and yourselves, wanting to look at a new model. What for you, when looking back, what would have made all the difference in terms of what happened to Courtney?
De-escalation, time. 41 seconds they gave my daughter. I put my rice in the microwave for longer than that. They did not assess. They did not take the information on board that was provided to them. They made an assessment in their own minds of knife, knife, knife. And that's where it ended. Courtney bled out on the side of the road with a bullet in her heart. Mental health is not a crime. Obviously, mental health issues can relate to crime, but in Courtney's case, it wasn't a crime. It needed a health response. The health response wasn't there. There were 2 mental health trained officers running across the road as the bullet entered Courtney's heart. They could have made the world a difference if those initial officers had have taken the time to assess the situation. My daughter may still be here. The right person, right care model. I have had some contact with New South Wales Police, and we have done training with New South Wales Police. I do think it's a positive way forward. I think, like anything in this, or in any area, funding is going to be crucial. Now, this shouldn't have to be about funding, but if we don't get enough funding for the right program to be rolled out for all officers, so that every client they are called out to, or every case they are called to, they are able to respond appropriately with the right person for the right situation they are involved in. It's important that we don't forget, although these people have mental health issues, that is not who they are. They are human beings, they are people. Courtney did nothing wrong that day. The coronial inquest told us that. We have an apology from Mick Fuller, but at the end of the day, my daughter's still dead. This needs to change. Health response is the way to go, in my opinion, at this point, but there are other factors, and it needs to be funded, and it needs to be legislated, so that when new government people come in, or people in the police, somebody comes in with new bright ideas, like tends to happen in a lot of organisations, and let's do this, and that previous things put by the wayside. This needs to be legislated to move forward, so that we as a society and the police are all able to have much better outcomes for ourselves, for our family, for our loved ones, and for the police who have to go out to these situations.
Thank you so much, Lisa. You bring in a perspective which is unimaginable for many others, and it is so important to hear your voice in this discussion. I'd also like to thank Kate, Dawn and David and Natalia, who's been helping us with the IT. I'd like to thank all of you for joining us today for this really important discussion. We hope that you've got something out of this discussion, and we look forward to looking at what happens in this space. Thanks for joining us.
Thank you.
Thank you.
Thank you.